Good afternoon to everyone, and welcome to episode 7 of our case study seminar or webinar for the Nclex. And I want to welcome those of you who are joining us for the first time. So anyway, our topic for today is a case study on HIV with opportunistic infection. So we can't begin our study of HIV without talking about immunity. And well, let me go back because I didn't do the introduction to HIV. Now, whenever we're talking about HIV, there are two types of HIV, HIV-1 and HIV-2. HIV-1 was discovered first and actually is the one that's prevalent worldwide. And HIV-2 is less pathogenic and is mostly confined to Western Africa. So when I will be talking about HIV, we're referring to HIV-1. The differences between HIV-1 and HIV-2 are not well explicated at this time. So it's not fully clear as to what the differences are between HIV-1 and HIV-2. So we cannot talk about HIV without talking about immunity. So our immune system response consists of humoral and cellular immunity. And when we say humoral immunity, it refers to the branch of the immune system that involves in the production of antibodies by B cells. So these B cells right over here on the left are going to be the ones that are going to actually secrete these antibodies. And antibodies in the body are known as Ig, or immunoglobulin, and there are 5 types of immunoglobulin. But that's all that we're going to talk about the B cells as far as the humoral immunity. So what is the purpose of this humoral immunity? Well, the purpose of humoral immunity is to build antibodies, also known as immunoglobulins, to recognize and also neutralize antigens. And they are the ones that remember disease processes so that when we are going to be exposed to it twice, we are prevented from having an infection again. So those are antibodies. Now, the other type of immunity is what's called the cellular immunity. And cellular immunity is a function of a form of white blood cells. And these white blood cells are called T cells. So they play a central role in cellular immunity. And in fact, these T cells are of 2 kinds. One, which is coded with a CD4 coding, and the other one is coded with a CD8 coding. CD stands for cells for differentiation. So basically, they are only of 2 kinds, CD4 and CD8. So what's the function for each one of these CD4 and CD8? So when we have the T cells right here, the H cells or helper cells are the ones that are lined with CD4. And the TC cells or cytotoxic cells are the ones that are lined with CD8. So what's the function of each one of these? So if an antigen, or let's say a microorganism or a germ, that's what's called antigen, comes into our body and it's detected, the CD4 cells are going to detect their presence. And that is why they're called helper cells, because they actually activate the cytotoxic cells to come and deal with this microorganism. And the cytotoxic cells, on the other hand, are going to come over here and they're going to capture this antigen. And once they capture it, these CD8 cells contain a poison. And these poisons are called lysosomes. And they release their enzyme. And once they release it, it kills this antigen, but it also kills itself. So it's a suicide mission. When CD8 are going to inactivate an antigen, they're not only killing the antigen, but they're also killing themselves. This is going to be very, very important for you to understand why it is in HIV that the body is going to have a decrease in your CD4 cells. And the reason for that is going to be part of this that we had just explained. Okay, so basically then we have two types of immunity: the humoral immunity, which produces antibodies, and these antibodies are known as immunoglobulins. So you have 5 immunoglobulin types. You have IgG, IgM, IgA, IgD, and IgE. So none of those are going to be something that we're going to be dealing with today, but we're mainly going to deal with the other branch of the immune system, which are the T cells, the CD4, and the CD8. Okay, so now I've talked about the CD4 and the CD8 cells. What we're going to do now is to look at the HIV virus itself. Now, when we look at the HIV virus, the shape of the virus is spherical. It's a sphere, and it consists of a core right over here, which contains the genetic material, and surrounded by this area, a protein envelope. So as you could see, there are many spikes. See the spikes right over here? These spikes are going to be very important. These spikes are proteins called GP120, which are connected to GP41 right over here. Okay, so that's GP120, and this is GP141. And you will soon find out what the role is in the transmission or the entry of these HIV into our T cells. Okay, so again, we have a RNA that is going to be contained inside the core right here. That's the RNA. And an enzyme that's also present over there is what is known as reverse transcriptase, as well as another enzyme here called protease, and another enzyme called integrase. So there are several things that are inside the HIV cell. So let's just talk about these enzymes first of all. All right, so the first enzyme is integrase. What is this integrase? This is an enzyme that helps or facilitates the integration of the DNA of the virus into the host cell's DNA. So this is a very critical step for the virus replication, as it ensures that the viral genetic material is passed on to when the cells divide. Now, what are these proteases? Proteases are the ones that are going to be like midwives, so that, let's say that this HIV, if this HIV attaches itself to a CD4, okay, so the HIV does not have any way of replicating itself. So it has to rely on the nucleus of the CD4 to multiply more HIV. So this is what happens. Let's say that I had a dirty needle and I injected myself with that dirty needle, and now that needle had HIV. Okay. So what's going to happen is this HIV is going to look for its favorite food. Any microorganism in the body has its favorite food, like the tubercle bacilli loves to eat lung tissue, and meningeal coma are also microorganisms that love brain tissue. Now, HIV loves anything with CD4. So what is the CD4? You remember this is the Th cells, the helper cells. And once it attaches itself, what's going to happen is it's going to integrate itself into the T cell. Okay? So now this HIV is going to have these enzymes, and you see this reverse transcriptase. This reverse transcriptase is now going to go into the nucleus of the Th cell and starts manufacturing HIV. So HIV is manufactured, HIV is manufactured, more HIV is manufactured, and so on. And pretty soon, when this cell is now full of HIV, it now is going to exit this cell to the enzyme called protease. Now, the reason why I'm talking about all these steps is because in looking at the therapeutic interventions, the drugs are designed to attack each one of these at some certain point. Okay, so you've heard about protease inhibitors, for example. Those medications stop these from coming out, and therefore they're going to not infect the other cells outside of this infected cell anymore. Okay, so those are the roles of all those things that are in there in order to manufacture as well as to replicate HIV. Okay, so let me see if you have any questions so far that I may answer. Any questions so far? Okay, let's move forward. Now, if you take a look at this particular illustration here, we have receptors called CXC3R4 and CCR5. So these are receptors for HIV to enter into the CD4 cells. So these are the doors upon which HIV is going to come into the Th cell. All right? So usually during the early part of HIV infection, CCR5 is used much more frequently. So let's see now and illustrate how the HIV is going to go. So the HIV is going to attach itself to here and then eventually will go. And as I said, the HIV has an RNA. And with the aid of reverse transcriptase, it's now going to manufacture more of itself. So you now have a lot more of HIV. All right, so let's trace the life cycle then of an HIV. So the first step in the infection of a Th cell is that the GP120 and the GP41, you remember the GP120, these things right here, and the GP41 of the HIV will bind with CD4 cells and usually enter into the doors marked CCR5. So you remember that CCR5? So they enter into the CCR5, and attachment occurs when the glycoproteins GP120 make contact with the CD4 receptor. So this is going to be the entry of the HIV into the T cell. Then the HIV now changes the material from RNA to DNA to the action of reverse transcriptase right over here. Okay, so some medications are going to stop right over here, and therefore it's important to understand that and to remember that. So if you were lost, so if this were the HIV and it had its projection, you remember the GP120 and also the GP41. So it attaches itself to the door, and the door of a T cell, the Th cell, is going to be your CCR5. You remember that? And then it's now going to go in, and the HIV does not have a nucleus. So it now invades the nucleus of the Th cell, and this is made possible through reverse transcriptase. Okay, so we're now in the stage where in the reverse transcriptase have now made the nucleus of the Th cell manufacture more T cells. I mean, HIV cells, okay? And as you could see over here, it moves on to going out, and this going out is going to be made possible by another enzyme called protease. And so some drugs will stop it right over here. All right, so let's go to the actual illustration or animation of how HIV attaches to the host cell. So as you can see in this animation, the HIV uses a protein called cyclophilin that is a component of its envelope, and it's now going to go into the T cell to the surface of the GP120. All right, so let's go to the next animation. The next animation is now going to be the entry of this particular HIV into the host cell. So it's now entering the host cell. And there it is going to invade the nucleus of the Th cell, and it's now going to make copies of itself. So you now have more HIV that's going to be manufactured. And later on, we're now going to have the exit of these new HIV. So let me summarize what we have talked about. So when a HIV virus enters the body, it now, in essence, enters the Th cells. And the reason why Th cells is the favorite is because it is lined with a special protein called CD4. So once inside the CD4 cell, so this is what happens. The HIV right over here is now going to have its RNA go to the DNA of the host and manufacture more of itself. So that's HIV going to be manufactured. So once HIV is going to be full right over on this cell, how does it go out? It goes out through the enzyme called protease. Okay, and so now more HIV is going to spread around the body. So that is how HIV is going to replicate itself and also infect other cells. So later on, we will find out that normal Th cells are now going to detect this, and they say, well, these are HIV viruses, but it looks like me. And that's why it does not kill it eventually. It does not ask for help. But some of the Th cells are going to recognize this and say, HIV is in there. So they send the T C cells, the killer cells, and they kill us. So you have HIV plus CD4, so you're killing HIV and CD4. So eventually, when your CD4 count is going to be too low, you're going to have AIDS. Okay, so this is HIV infection at the beginning. This is AIDS at the end. All right. So again, let me simplify it. HIV comes, it attaches itself to Th cells. Th cell now manufactures a lot of HIV because of reverse transcriptase. Once HIV comes out, it's now HIV plus a little bit of CD4. Similar to you, you're not a product only of your mother, you're a product of your mother and father. So you now have HIV CD4. Now, there's another type of white blood cell called CD8. This is the cytotoxic cells, and their function is to kill any antigen. So they kill these things. So what do they kill? They kill two things. One, HIV, and number two, they also kill CD4. So do you understand now why in AIDS, we have a decrease in our CD4 count? All right, let's take a look at our first question to see if you understood what we had talked about. Okay, so the correct answers are letter A and letter C. Why is option B incorrect? It should say inside the virus is packaged RNA, not DNA. Remember, it doesn't have any DNA, and that is why it relies on the Th cell to manufacture more HIV. Option C is incorrect because it should say the glycoproteins, specifically GP120 and not GP140, are vital for engaging the receptor on the target cell. Oh, that's letter D. It's GP120, not GP140. So it should be A and D. I'm sorry. Okay. Let's go to another question. Are you seeing the question, the poll?
Yeah, it went away.
This one, there is an active poll going on or not?
No.
No. So let me see why it's not activating. So I ended this. And now I want to poll this. It's not showing at all. So anyway, just let me know which one is going to be your answer. Can you chat me your answers?
Oh, I'm not muted.
So it's not true. Which statement below is not true regarding the role of helper T cells or T8 cells? There you go. I think I accidentally hit something and now I can launch it. There you go. Okay, so letter C is incorrect. All the other options are true statements about the helper T cell. Option C is the T cell is cytotoxic. That would be TC cells or the cytotoxic cells, CD8. Okay, very good. Let's go to the next one. Okay, so it's in the word itself. It says, what step does HIV unite and dumps? That is the fusion stage. They're going to join with one another. And then the HIV will now dump the contents into the target T cell. All right. Okay, I think there's some confusion over here. The correct answer here is oh yeah, integrase, not going to be your all of you answered protease. Okay?
Why is it not protease, but you said that it exits the cell?
Yeah. Once inside the nucleus of the host T cell, the HIV releases an enzyme called, there are two enzymes that are released, the reverse transcriptase and the integrase. The reverse transcriptase, you remember the reverse transcriptase, what is its role? Normally, when we need to go back to basic physiology, but when this is a cell and this is the nucleus, usually the nucleus contains the DNA, right? Now, usually when this cell wants to manufacture itself, it sends RNA, messenger RNA, oh wow, right over here to the other rRNA. And they're now going to manufacture, let's say these are red blood cells, more red blood cells. So that's the normal process from the nucleus, DNA, to the outside, to the RNA. Now, whenever you have your HIV, right over here, and your T8 cell, you're going to have to integrate these two together first, okay? And then the reverse transcriptase is going to occur. And the function of the reverse transcriptase is it is now going to remember the HIV does not have a nucleus, right? And it contains an RNA material. And so it injects its material over here so that it could be manufactured with more HIV. So when we have now a lot of HIV, this cell can no longer accommodate a lot of HIV or any more HIV. It's going to allow this HIV to exit. And that is the role of protease. So protease occurs last. Okay?
Okay. So can you go back to the question a minute, please?
Sure. Once inside the nucleus of the host cell, HIV releases an enzyme called, all right?
Oh,
Okay, so it's at the beginning, it's not at the end. If it is the end, it's going to be protease.
got it. Thank you.
Yeah, sure. Okay, so let's go now to the meat of the matter. So how HIV transmitted? And, you know, I was taking my master's degree when HIV became such a world problem. And that's why I had a lot of interest in this. And I used to work at Jackson's at the immunity floor. And we had a lot of patients, and we actually didn't know at that time exactly how it was transmitted. But basically, we knew that sexual transmission was the major mode, and of course, also sharing needles, dirty needles. So as you could see in here, the majority of the transmission of HIV is through unprotected sex. And when we have these sexual activities based on a scale, the most dangerous will be anal penetration. And then, of course, followed by vaginal penetration. Then needle sharing. This is the second major way in which it is transmitted. And in fact, here in Miami and also in Broward County, that's our problem as far as drug addiction is concerned. And needle stick injuries from healthcare workers and other individuals, that's around 36%. I used to work with a nun at Jackson. She was African and she got stuck by a needle at that time. And in 6 months, she was dead with AIDS. And then, of course, a lesser percentage is from vertical mother to child. So during pregnancy, there's going to be a vertical transmission, and also during nursing, and that is around 5 to 15%. However, when a person has a viral load above 400, the transmission actually becomes lesser and lesser. So, in other words, what are your chances of getting HIV when you got it through, let's say, a patient who's on full AIDS, okay, versus a patient who is HIV positive? The likelihood of you getting infected will be with the person with AIDS. So let's differentiate actually what HIV and AIDS is, because some people do not understand the difference between the two. HIV infection means to say that you now have the HIV virus. So this is HIV infection. And HIV infection goes through several years, and you might have this infection for many, many years. And then, though, your CD4 count begins to fall down. And as it falls down to less than 200, you have an opportunistic infection. And an opportunistic infection is something that takes opportunity of the fact that you have a diminished immune system. And so you might have TB, pneumocystis carni pneumonia, and Kaposi's sarcoma. All these infections are now going to be defined as AIDS. Okay, so this is the marker. If the CD4 count is going to be less than 200, then by definition, you now have AIDS. The lowest CD4 count that I've seen in a patient is 2. And you heard that right, 2. And normal is up to 1,500. Okay. All right, so let's take a look at the clinical manifestations of HIV. HIV has 4 categories with specific manifestations for each stage. And this is going to be experienced during the early infection stages. People who are acutely infected with HIV experience this flu-like symptoms, and they're going to have fever, maybe, of around, and diarrhea, which might exceed approximately 1 month in duration. So here are the clinical manifestations of the early infection stage. So you might have lymphadenopathy, hepatomegaly, splenomegaly, dermatitis, parotitis, that's the inflammation of the parotid gland, and recurrent persistent URIs or upper respiratory infection, sinusitis, or even otitis media. Then it's going to progress even more into moderately symptomatic, and this would include your HIV-related signs and symptoms, such as herpes zoster and candidiasis, vaginal candidiasis, as well as all these things that are listed here, including hairy leukoplakia. And the other category of infections is the severely defining characteristics of AIDS. And this would include your HIV, wasting syndrome, cryptococcal meningitis, Kaposi sarcoma, and so on. So we'll go back to all these opportunistic infections later on. Okay, so let's say that I have had an exposure to HIV. So I might not develop the HIV antibody right away, okay? So that would be classified as a primary infection. This is the period of infection from HIV to the development of HIV-specific antibodies. So in this stage, this is still going to be, the patient is still going to be HIV negative, right? So the primary infection is up to, this is the HIV negative. And then now I detect the antibodies. I now am going to be HIV positive. All right. So the next stage is going to be your HIV asymptomatic, meaning to say that after the viral set point is reached, HIV positive people now enter into a chronic stage in which the immune system cannot eliminate the virus despite its best effort. So that's the asymptomatic stage. And now you're going to go into the symptomatic stage. And these are when infected individuals are not included in the categories of AIDS, but they are in between. Okay, so in CDC category C, this is when the CD4 count now is 200. And this is now AIDS. So I hope that that was clear. The beginning, you are HIV negative. So you got contaminated. You will not have a positive HIV test right away. Then you become HIV positive. And you might have a long period of time wherein you don't have any problems at all. Okay, so that's going to be asymptomatic. And then you begin to have symptoms.
Asymptomatic is an adjective characterizing conditions carried without experiencing symptoms, despite an explicit diagnosis.
Is that your Alexa?
Alexa, he's joining this class. I didn't invite him. Sorry about that. All right, so where was I? So HIV and positive, and there are no problems, and then the patient becomes sicker. And once they reach a CD4 count of less than 200, then they now have AIDS. Okay. All right. So I hope that you emphasize to your patients the difference between HIV infection and AIDS. So not all patients with HIV have AIDS, and all patients with AIDS have HIV. Okay, so over here, this is the definition of HIV infection among adolescents according to the CDC. And as you could see over here, stage 1, that means to say that there's still a lot of CD4, and that's more than 500 cells. And of course, this one less than 200 is going to be one that there's documentation of HIV, of AIDS. Okay, let's go to this poll. This is slide 26. Okay, so the answer is letter C. You remember it doesn't have a DNA, and so it relies on the DNA of the host cell, that means to say the helper cells, to manufacture itself. So it turns viral RNA into viral DNA. Okay, so the answers are C and E. HIV cannot spread to tears or to sweat unless, of course, if it's contaminated with blood, which rarely occurs. So HIV is primarily transmitted to fluids, body fluids, that is, like breast milk, blood, obviously semen, and also vaginal fluid. Okay, so let's go now to the diagnostic staging of HIV and AIDS. So the first test that we're going to do are your antibody tests. By the way, HIV tests are very accurate, but no test can detect the virus immediately after infection. So how soon a test can detect HIV depends on the type of the test that's being used. So there are 3 types basically of HIV tests: your antibody test, your antigen antibody test, and lastly, the NATs, or the nucleic acid test. So let's take a look at antibody tests. So what is an antibody test looking for. You remember immunoglobulins, they're looking for antibodies to HIV in a person's either blood or oral fluid. So these antibodies can take 23 to 90 days to detect HIV after exposure. So these are going to be, what do you call that? Something that is going to be delayed as far as detecting the virus. So the second type of test is the antigen antibody test. And when we say antigen and antibody, we're looking for both the HIV antibodies as well as the virus itself, or the antigens. So antibodies are produced by a person's immune system when they're exposed to viruses like HIV. And antigens, once again, are foreign substances that causes a person's immune system to activate. So if a person has HIV, an antigen called P24 is produced before the antibodies develop. So this is going to be the thing that we're looking for, is the P24, the antigen P24. So these antigen antibody tests are recommended for testing in laboratories that are common in the United States. So it could detect exposure between 18 to 45 days. So as you could see, it's a little bit faster than the antibody test. So this usually is going to be a test that is going to be better than an antibody test. All right. And the other thing is going to be the NATs. So NATs look for the actual virus in the blood. So this test should be considered for people who have had a recent exposure or a possible exposure with early symptoms of HIV. It usually can detect the presence of the actual virus, not antibodies, within 10 days to 33 days after exposure. Okay? So NATs, again, is for nucleic acid test. Let me write that down. So,
And more than one of these be done at the same time?
it depends on the acid test, on the interest of the individual or the provider. If I want to know right away, for example, you come in and you had been exposed around, you said, 15 days ago. So it would be foolish for me to have an antibody test, right? Because it would not be visible until around 23 days to 90 days. So I'm going to order, let's say, NAFs. But let's say your contact was 4 months ago. Well, that means to say that you would be positive with the antibody test. So I would order the antibody test. Does that make sense, Chantal?
Yes.
Mm-hmm. So it depends on what the exposure period is and what purpose you're doing it for. Okay, so the other tests that are going to be important in patients that we suspect of having HIV is going to be your CD4 T cell count. So you remember, these are white blood cells that are specifically targeted by HIV. So when this CD4 count is going to are going to be very important to determine whether or not you have HIV or you have AIDS. All right. So the other name for CD4 cells are called T T lymphocytes or T8 cells or helper cells. Okay, so that's the other name for CD4. So it's the amount of or number of blood cells in cubic millimeter of blood that is counted to represent all the CD4 cells in your body. So usually a normal CD4 count is anywhere from 500 to 1500. That's the normal. And again, what is the definition of AIDS? The definition of AIDS is that you're going to have a CD4 cell count of 200. Okay. Now, another test is what is known as viral load. And a viral load measures the amount of virus in your blood. So I'm always, what do you call that? Entertained when students ask me, what is the normal viral load? What should be the answer? What's a normal viral load? Should be 0. Okay? Because you remember, it's looking for the HIV. So why do we have a viral load test? Well, this is going to be very, very important in order to determine the effectiveness of therapy. So let's say that I started you with antiviral therapy, and your viral load was something like 500. So hopefully that this viral load is going to diminish all the way to hopefully undetected or 0. So you have heard of individuals, for example, who have had HIV and they have been treated with medications and now they're undetectable. So that's possible. Undetectable means to say that the HIV viral load is 0. All right? And the last test that we usually do is going to be drug resistance. Some strains of HIV are resistant to medications, and therefore this is going to help us determine what form of drug we're going to be using. So this is going to be a common test now, that whenever we find somebody who is HIV positive and we want to treat them, we want to have a HIV drug resistance testing, because it's very frequent here in the United States because of mutations that there are going to be drug resistance. Okay, so other things that we are going to...
I have a question.
Sure, go ahead.
If their viral load is 0, could they still spread the
No,
virus?
they don't anymore. Now, the
That's what I
postulate,
thought.
and this is the theory, okay? You've heard on TV, they don't have to have protection anymore when they're undetected. But anyway, the thing is that even though you are now having a viral load of 0, the theory is that these particular HIV have now entered into cells that cannot be detected by blood. And that is why it's still a wise decision for anybody with a HIV history and a 0 viral load to have precautions as far as transmission is concerned. That's a very interesting question. Okay, so we all know that these diseases that are listed over here are going to be common diseases or infections that is going to be present in patients with AIDS. And therefore, we order tests in order to look for tuberculosis, for hepatitis B and C, sexually transmitted infection, and UTI. I'm sorry about the YUTI. urinary tract infection, as well as of some forms of cancer like Kaposi sarcoma, and this usually could be found in the cervical canal as well as in the anal canal. And then, of course, for cytomegalovirus and toxoplasmosis. Okay, let's go to another poll. This was the one that I accidentally clicked earlier, and that's why I couldn't click anymore. All right. So abnormal laboratory findings seen with AIDS include, all right. So would you have a decreased CD4 and T cell count? And the answer to that is yes. So this is going to be a correct response. And how about the P24 antigen? Do you remember the P24 antigen? That's the second test that we have. So this is going to be present also because you cannot have AIDS without having HIV, correct? And then, of course, positive EIA test, that's the ELISA or enzyme immunoassay, is used to detect the antibody. So all these are going to be present, okay? All right, so let's go to this one. This one I didn't contaminate, so I could activate it. Okay, very good. It's the CD cells, CD4 cells that are infected. So the answer is letter B. So CD4 cells are also known as T8 cells or T helper cells. Very good, yes. That means to say that antiretroviral therapy now has been effective in decreasing the viral load. Okay, let's go to the next one. Okay, so let's take a look at this question right over here. So we know that AIDS occurs when you have a CD4 count of less than 200, or also when you have an AIDS-defining illness, and I will explain that later on. So the CD4 of 1,000 is going to be very high. So this is going to be a not going to be a person with AIDS. This one, HIV client with CD4 count of 500. Again, this is high and no other symptoms. So this could not be a diagnosis of AIDS. An HIV unknown complained of candidiasis of the mouth, vaginal herpes simplex virus, and TB. Again, I mean, you can have candidiasis or vaginal herpes without any HIV, without any AIDS. So this would be incorrect. An HIV client with CD4 count of 300 cells and wasting syndrome. Okay, so this is one. And E, an HIV client with CD4 count of 100 cells, and this would be the presence of TB. So this is definitely correct. So letter E is the best response over here. In letter D, the thing is that wasting syndrome can be seen also in patients with cancer. And so I think we have been tricked in this question because it says select all that apply. And therefore, we were thinking that it probably will have more than one response. But I submit that there's only one response that's correct over here. Okay? All right. So let's go to examination of a patient with HIV, maybe suspected of having AIDS. So a complete physical examination should be performed at the initial encounter. And we usually are going to pay very special attention to the skin, to the mouth, to the lymph nodes, because these are going to be the areas that would manifest a lot of symptoms of HIV and AIDS. So let's go to the skin. What is it that would tell us that maybe a person is having an advanced HIV disease or even beginning of AIDS? Well, we look for rashes. So we also look for the presence of Kaposi's sarcoma. And Kaposi's sarcoma, I'll have it in the slides later on, but it will, over here, as you could see at the legs of this patient, he has a lot of Kaposi's, and Kaposi's could occur anywhere in the body, including the GI tract. Okay, so this one is one in the skin. The other thing is that we look for the lymph nodes, as you could see over here on the cervical lymph node. And this is the manifestation that perhaps the patient has the opportunistic infection, parotitis, or it could be carcinoma. And then the oropharynx, this is hairy leukoplakia, and anorectal areas, this is going to be your herpes virus, an example of that. Okay, so what are some of the diagnostic things that we're going to do? Well, CBC is important. Why CBC? Because it shows us whether or not our WBCs are going to be decreased. And we also would like to have a PPD. And why a PPD? Because tuberculosis is a very common opportunistic infection. And serology, we would like to have an HIV screen like ELISA or Western blot. And by the way, Western blot has been recently eliminated. You don't have to have confirmation with Western blot anymore in order to diagnose the presence of HIV antibody. Before, it was mandated that it had to be either going to be confirmed by an ELISA or a Western blot test, but not anymore. And then, of course, viral load, which I already talked about, STD screening, as well as cultures. And when I talk about cultures, it could be blood cultures. It could also be other types of cultures, like maybe fluid that is coming out from somewhere could be cultured to identify the microorganism. All right. So it would include also chest X-ray, pulmonary function tests, neurologic studies as appropriate, and then barium swallow, because you remember I said that Kaposi's could be present in the GI tract as well. In fact, it's one of the most common causes of uncontrolled diarrhea in patients with AIDS. Okay, so I see that everyone has different answers. So what is the keyword over here? The nurse is assessing clients at a clinic which signs indicate primary HIV infection. So this is phase 1, or primary infection or acute infection. And usually when you have an acute infection, you have signs similar to having a flu. So you will have an increase in viral replication, which leads to a very high viral load, and also a decrease in your CD4 cell count. So a CD4 of 800 appears to me to be high. A CD4 of 200 or less is a sign that the patient has AIDS, not primary infection. So we can eliminate letter B, because remember, this is the defining characteristic of AIDS, not HIV. Okay, the question says primary HIV infection. And CD4, letter C, CD4 of 1,000 over 1,000, that's too high. I think the correct answer over here is that you're going to have a decrease in your CD4 as well as constitutional symptoms. And this would include, like, you're having flu, a fever, a sore throat, and muscle aches. So letter A is the correct response. All right, so EF test is going to detect the immunoglobulin or the antibody. The correct answer, you're correct, viral load test. It measures the RNA levels and tracks the body's response to HIV infection. Could also be used to evaluate the effectiveness of treatment. All right, so how do we treat, or how do we manage patients with HIV as well as AIDS? Well, the medical management focuses on the treatment or elimination of opportunistic infections. So why the word opportunistic, by the way? So remember that when we have a CD4 count of 1,500 or 1,000 or over 500, our immune system is intact, right? But as our immune system is now declining, so with CD4 counts that are going down, infections can easily, therefore, enter the body because we do not have our primary defenses anymore. And that is why it's called opportunistic infection. And one of the most common opportunistic infections that occurs along with HIV and AIDS is pneumocystis carni pneumonia, or pneumocystis jirovecii pneumonia. It used to be called pneumocystis carni pneumonia. And we would manage these patients with TMP and also SMC, or azithromycin, or clarithromycin for mycobacteria, as well as amphotericin for cryptococcal meningitis. So these are all medications that addresses specifically the most common infections. So our common infections are your PCP or PJP, your mycobacterium or TB, and your cryptococcal meningitis. So other things that we do are going to institute antidiarrheal therapy and antidepressant therapy to treat depression, and as well as nutrition therapy for patients who have unexplained weight loss. And this is going to be very important in order to decrease the incidence of HIV wasting. Okay, so these are the opportunistic infections that occur more frequently and are going to be observed in anybody who has a weakened immune system. So they're also called AIDS-defining conditions. That means to say that if a person with HIV has one of these conditions, they are diagnosed with AIDS, the most serious stage of HIV infection. All right. So tuberculosis is one. Bacterial respiratory infections, bacterial enteric infections, all these are bacterial infections. You could also have viral infections like varicella zoster, leukoplakia, hepatitis, herpes simplex virus, cytomegalovirus, and so on. So you could have bacterial, viral, fungal, parasitic, and other infections that is going to be an AIDS-defining infection. So that includes your dementia, invasive cervical cancer, non-Hodgkin's lymphoma, as well as Kaposi's sarcoma. So all these are going to be opportunistic infections, including your candidiasis, invasive cervical cancer, cocci, deomycosis, and cryptococcosis. All these are going to be opportunistic infections. So you don't need to memorize them, but the presence of an infection along with a CD4 count of 200 is going to qualify for the diagnosis of AIDS. All right, so there are several of these, and one of them that I wanted to just highlight is cytomegalovirus, or CMV. And this is a virus that can infect not necessarily just one part of the body, but multiple parts of the body. And they can cause actually pneumonia, as well as gastroenteritis, even encephalitis are going to be common with CMV. One thing to note is that in the past, I had a friend. We used to work at Victoria Hospital. That hospital has since closed in Miami. But we were in ICU, and he was taking care of a patient that was on a ventilator. And unfortunately, the ventilator got disconnected. And so my nurse friend rushed to the patient's bedside. And when he rushed to the bedside, the patient coughed and he spewed all this mucus and it went into his eyes because he ran to reconnect the ventilator. Well, he got blind. And so he's no longer practicing as a nurse. Actually, he didn't practice as a nurse. Maybe a year after he contracted CMV retinitis, he got blind as a result of that. So whenever you're taking care of patients that has the possibility of you getting the microorganism, make sure that you always have your protective equipment at hand, because you never know what's going to happen. Okay, so as I said, in the 1980s, when HIV first started, most of the patients that came are actually very, very sick. But nowadays, you're lucky because most HIV patients are now being treated, and therefore we don't see as many AIDS patients anymore as we used to see in the 1980s. Nonetheless, you still need to be very careful. Okay. Another infection is going to be, this is what I was looking for earlier. This is an enlargement of the Kaposi sarcoma. Once you see it, you'll never forget it. And I've seen millions, thousands of them. And that's the typical Kaposi sarcoma. Lymphoma could also be noted in patients with AIDS, as well as tuberculosis and Mycobacterium avium complex. What else? Okay. So again, this is pneumocystis carni pneumonia. Let me just write down the correct or the most updated term to have pneumocystis carni pneumonia. And pneumocystis jirovecii is now called. So you could hear it as PCP or PJP. All right. Okay, so pneumonia, progressive leukoencephalopathy, as well as salmonella, all those are going to be, what do you call that? Opportunistic infections. All right, I wanted to talk a little bit about toxoplasmosis. This is an infection that is caused by a parasite. This parasite is called Toxoplasma gondii. And this, the reason I'm saying this is because it's very commonly transmitted. The parasite is carried by animals, including cats and birds, and they release this parasite through their stool or their feces. So therefore, people can develop it by inhaling the dust or eating contaminated food with the parasite. And so this is going to have an implication. If you see this question, which in the past has come out in the Nclex, a patient has toxoplasmosis, they are not supposed to have a cat, or they should not take care of the cat litter at all. All right? So litter boxes could be changed safely by other individuals when they wear gloves and washing their hands thoroughly with soap and water afterwards. All right. So where is this infection usually going to be predominant? So this parasite primarily loves the brain, and therefore all the neurological symptoms that you can think of is going to be present. And actually, this could also cause what is known as a wasting syndrome. And wasting syndrome is when you have a loss of more than 10% of your body weight. And the loss is mostly muscle mass. So remember this one. If you have more than 10% loss in your body weight, that is going to be the definition of wasting syndrome. Okay, so let's take a look at this. The patient has oral candida, right? So I don't know if you have ever seen oral candidiasis, but there's a lot of patches and breakage in the mucous membranes of the mouth. It is going to be punishment if you give the patient citrus juice, because it's almost like putting vinegar on your wound. So letter A is incorrect. Select foods that are soft or puree. This is the correct answer because it's going to be very difficult for a patient to chew anything when they have oral candida. And letter C, rinse your mouth often with a commercial mouthwash. And that commercial mouthwash is going to be the key over there because the key component of commercial mouthwash is alcohol. And that is why, I don't use Listerine. I don't use any of those commercial things because it actually kills cells in your mouth. So if you have oral candida, you'll have more cells that are going to die. So it is much better actually to use hydrogen peroxide as a mouthwash rather than these commercial mouthwashes because of the fact that commercial mouthwashes have alcohol in them. All right, so letter C is a no-no as well. And extremes of temperature, like hot soups and beverages with each meal, is going to be very difficult for a patient with oral candida to swallow. Okay, so the correct answer is letter D, pneumocystis pneumonia. Actually, it can affect almost like 80% of individuals that are infected with AIDS. All the others, like cytomegalovirus, Legionnaire's disease, and mycobacterium, are not as common as pneumocystis jirovecii pneumonia. Okay, I think you got this correctly because everything should be manifest in patients who have neurological involvement as a result of AIDS. So this includes this, and this, except for hemiplegia. Hemiplegia is more or less a pathology in one hemisphere of the brain, which would not be present in a patient with a viral illness. It would be present in a patient with a vascular problem, such as cerebrovascular accident. Okay. All right, so you remember this slide right over here, this slide. A loss of more than 10% of body weight is going to be a characteristic of wasting syndrome due to HIV. So the correct response in that question is letter A, 10%. All right, let's now go to patient teaching. So what are some of our obligations as far as patient teaching is concerned? Well, we should talk about medications as well as vaccines and prevention of exposure to STD or sexually transmitted diseases, as well as limiting exposure to germs. And we should always emphasize that they should eat only dead food. What do I mean by that? Anything that's not cooked is going to pose a danger to them. So salads would not be ideal for them, or undercooked food like sushi, for example, or anything like that would not be very good diets for these patients. And of course, avoiding cat litter. All right, so let's go to the vaccines, because we talk about making sure that we talk about vaccines. So what do we tell patients as far as which one is going to be recommended and which one is not going to be recommended? And whenever you are going to have a teaching with them, you recommend those things that are inactivated vaccines. And this would also include COVID-19, right? So how do you remember the inactivated vaccines? Well, they include your rabies. So that's inactivated. You could also include influenza, as well as polio. So these are going to be vaccines that are going to be safe for them. What are not recommended? Well, your Haemophilus influenza type B, your live attenuated influenza vaccine, your MMR, measles, mumps, rubella vaccine, as well as your varicella vaccines. So these are not going to be vaccinations that are ideal for patients with HIV and also with AIDS. Okay, so the way in which you remember, and I always talk about this, live vaccines, whenever you have live vaccines, the way that you remember, and I'm sure that you have already heard about this, Rome is the place to go. Have you heard about this? So this is an easy way to remember them. And R stands for rubella. O would be for oral polio vaccine. M is for measles. And E is for epidemic typhus. So these are live vaccines. And so again, I would be influenza. You should remember, Rome is the place to go. No, I can't remember this. This one is typhus. Plague. And gee, I apologize, but I can't remember the rest. But anyway, please look that up. It's in YouTube. So Rome is the place to go. Rome, we did that. I, we did that. T, we did that. Oh, okay. So this S is not there. Place to. Oops. Sorry about that. So anyway, could you please check that out? Because that's a good way to remember the live vaccines. Because there's some questions on Nclex, particularly in cancer or immune system disturbances, that you do not want to give live vaccines. Okay. All right. So we already talked about pneumocystis carinii pneumonia. And what I wanted to do is just talk a little bit about the clinical presentation of these patients. So how do you know that somebody has pneumocystis? Well, the presentations usually is going to be a progressive difficulty of breathing, and sometimes or most of the time accompanied by fever. And the reason why I tell you sometimes that's accompanied by fever, by the way, patients who have AIDS usually do not mount fever. Why is that? Because fever is an immune system response. When you have AIDS, you don't have any immune system anymore, and therefore it does not produce a fever. Okay, so just because a patient with AIDS does not have a fever doesn't mean to say that they don't have any infection. In fact, it is going to be most of the time, or all the time, I should say, that they have an infection present. So it might be a trick question, okay? So if you have AIDS, you might not have fever. If you have HIV and not AIDS, then you can mount a fever. Non-productive cough, chest discomfort, weight loss, and on examination, we will always have the tachypnea, which is very, very common in your crackles and your rhonchi. And that is the reason why they usually are going to require intubation and mechanical ventilation. So most of the patients who come in with pneumocystis are going to end up being on a ventilator. And to treat the infection, your TMP-SMX, your trimethoprim sulfamethoxazole, is going to be the agents that are going to be the choice for this particular individuals. Now, because they're so ill, they always have to be in critical care. And the mode of transmission of the pneumocystis is not going to be airborne. So it is a standard precaution. This is a common question in Nclex, right? PCP does not require respiratory isolation or airborne precautions. It only requires standard precautions. Obviously, you're not going to place them in the same room with somebody who is immunocompromised, because if you put them with a patient with cancer, obviously the patient with cancer will soon get the pneumocystis pneumonia. Yeah, again, this is a very tricky question, because the clinical manifestations of PCP are going to be cough and fever, as well as shortness of breath and weight loss. And so interstitial infiltration chest x-ray, this would be a correct response. But respiratory rate of 32 with normal breath sounds, that's not going to be characteristic of patients that are going to be having PCP. And I wonder if this is a question that should have been accepted. All right, stridor is not characteristic of pneumocystis. What does stridor indicate? This is an upper airway obstruction. And use of abdominal muscles is not characteristic of PCP. Night sweats, this would be for TB. So I imagine that this probably is an accept question instead of SATA. Apologize for that. That came from Lippincott. All right, so in caring for a patient with pneumocystis jirovecine pneumonia, what interventions will the nurse implement? Okay. You are correct. It is universal precautions. You know what? It's now 5:40. I forgot all about it. I'm yakking my mouth and I forgot to have a break. Can we just go ahead and finish, because we're almost done?
Yeah, that's fine.
Okay, great. So let's go to the case study now. And so let's take a look at the situation. The nurse cares for a 25-year-old male with a history of HIV, admitted to the medical surgical unit with respiratory distress. Okay, so at 11 o'clock, the nurse's note says 25-year-old, HIV for 3 years, admitted for a dry cough and fever of 101. The client has fatigue, shortness of breath, respiratory rate of 28, pulse ox of 90% on room air. Breathing is slightly labored, and he has a tight feeling in the chest when taking a deep breath. He has been on antiretroviral medication since his diagnosis of HIV, but recently stopped taking the medication, oh bad boy, when he was laid off from his job. His symptoms did not improve with over-the-counter medications after 3 days. IV started in normal saline, IV infusing in the right arm at 75 cc's per hour, laps drawn, bronchoalveolar lavage completed, the cytology report is pending. And you see all these laboratory reports, which are BUN is okay, creatinine, yeah, it's okay, hematocrit, okay too, hemoglobin, okay, WBC, it's high. Platelets is okay, PT is okay, PTT, APTT is okay, potassium is okay, sodium is okay, and CD4, more than 178. Okay, this is less than 200. Boy, oh boy. Okay, so the nurse reviews the client's laboratory report. Which laboratory findings are going to be concerning? Select all that apply. So once again, I show you this. And now we go to the question. The WBC, okay. So have you identified which one you're going to choose? Yeah, it's hard because you cannot see the lab report. So I'm going to show you again. So everything is normal except for the WBC, right? It's 15.2. And the CD4 count, 178. The sodium is elevated, but it's not a concern right now. I mean, it's negligible. So I think it's just the WBC and the CD4 count. Okay. So let's go on to the next one. The next question is, which client findings are risk for an opportunistic infection? Select all that apply. So it's asking us which ones are risk for an opportunistic infection. All right, so what did the patient do? He stopped taking his medications, right? So when you stop taking your medication, you will have an increase in your viral load again, and therefore it's going to make the CD4 count less, and you're now going to be at risk for the development of opportunistic infection. So the correct answer here is history of HIV. That's one. And then the other one, being 25 years of age is not going to be a risk. And use of over-the-counter medications is not also a risk. So this history of HIV is going to be it. Stop taking his medications with the low CD4 count that increases its risk for an opportunistic infection. Okay, so those three. All right, let's go to question number 4. The nurse reviews the client's chart. So we're now going to number 65. Complete the sentence. The nurse should first address the client's fever, immunity, infection, or oxygenation. I already spent the poll, so I couldn't give you the poll. So could you just tell me which one of the 4, 1, 2, 3, 4, the nurse should address first the client's what? Is it fever, immunity, infection, or oxygenation? You can't read it? I don't have a poll for this. Apparently I clicked it and
You go back to the paragraph.
yeah. It was the same thing that we saw before. He has shortness of breath.
It would be oxygen.
And respiratory rate of 28 and pulse oximeter of 90%. Okay. Yeah. So yeah, the correct answer here would be oxygenation. All right. And I have the other poll, the next one. Oh, it's in there. So let's go to next. The nurse should address the client's fever, immunity, infection, or oxygenation. We already did oxygenation at first. All right, so if you address the fever, you're going to give antipyretics, right? If you're going to address the infection, you're going to give antimicrobials. So which one do you do first? So I guess the infection has got to do first, right? So the next priority is to treat the infection. The patient will need to resume the antiretroviral therapy that he was on. So the client is diagnosed with PCP. The broncho lavage shows pneumocystis jirovecii right here. So which means that he is positive for PCP. So our next question is, the client is diagnosed with pneumocystis pneumonia. For each potential order, specify if it is going to be anticipated or not anticipated. So let's answer this one. Okay, so let's see if one is anticipated or not anticipated. Titrate the oxygen to keep the pulse oximeter above 95%. I think this is good, right? Because his pulse oximeter was 90. Administer ibuprofen PRN for fever. This is also good. Actually, ibuprofen is much better than Tylenol for the control of fever. And then TMP, SMX, or trimethoprim sulfamethoxazole, is specific for PCP. So this is good. Not vancomycin. Okay, vancomycin is not the drug of choice for PCP. And then, of course, schedule a stress test. No, he's very sick. Refer to social work. Obviously, this is going to be good because he lost his job, you remember? And gargle with lidocaine solution. There was no indication that he had any oral problems, so that would not be anticipated. Okay, so the nurse teaches the client about how to reduce the risk of opportunistic infections. So this is the only one that's new in our case, is the statement right over here. Right. So what should the nurse teach the client about preventing opportunistic infections? So you're going to select all that apply. Okay, so you remember the strategy for select all that apply, only select the ones that you are confident with because it's right minus wrong, okay? So would you teach him about using frequent hand washing? I think so. I mean, this would be important for anything. And because of his CD4 count of 178, I think that he should also get tested for tuberculosis. Do you have to have an HIV test every 4 months? No.
He's already diagnosed.
Yeah, you already have it. So what needs to be done actually is either your CD4 count or your viral load. Those have to be done periodically, but not HIV tests. Okay, so the CD4 count as well as the viral load is the one that's going to be done on a serial basis. Get tested for sexually transmitted diseases or infections. Obviously, that would be good. Get a yearly influenza vaccine. That also would be good. Don't drink untreated water. That's also good. Have a monthly complete blood count. Again, this is not necessary. Okay, so the CBC, it should be either a CD4 count or your viral load. That's the one that we have to monitor. All right, have viral load testing every 4 to 6 months. That is correct. And of course, taking your antiviral medications as ordered is also going to be correct. Okay, so let's go to the last scenario. And it says, the nurse assesses the client's understanding of the teaching provided on the risk of infections. So now we're going to evaluate whether or not he understood it. So what indicates understanding of instructions? Okay, so this is interesting. All right. So my CD4 count, my low CD4 count shows that I'm at higher risk for infection. That certainly is a correct statement. So that would be understanding. I should avoid crowds when possible. Very good. It's a good practice to keep hand sanitizer. Very good. I can stop wearing a mask when I feel better. Oh, no, 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 no. Washing my hands frequently is one of the best ways to prevent infection. Understanding. I need to keep using safe sex practices. Understanding. I will schedule a HIV test every 6 months. No. Remember, what do we do serially? We do CD4 and what's the other one? What's
Viral load.
Viral load. Yes. Okay. I will stay current with my vaccinations. That's good. Eating a balanced diet and maintaining good nutrition will help improve my immune system. That's good. Not taking a full course of antibiotics could put me at risk for future drug-resistant infections. That's exactly what causes your drug resistance. So that is going to be correct response. All right. So we finish HIV, and I hope that you have now gained an understanding of HIV/AIDS as well as opportunistic infections. So
Yes.
I look forward to seeing you tomorrow, and you all have a good evening.
I have a question with the last. Can you go back to the question?
Sure.
I didn't pick the last one because I know that it helps to maintain your nutrition when you eat a balanced diet. However, I was thinking because the patient does not have a strong immune system, would that help? I don't know if I was thinking through.
Yeah, okay. So yeah, you were taking it, you're adding an incident to the question, okay? So don't add any situation. So just read it. It says, eating a balanced diet and maintaining good nutrition will help improve my immune system. That's a general statement. It didn't say that I will incorporate salads in my diet or anything like that. That's the one that would be incorrect, would be undercooked or not cooked.
Okay, so if it was more specific about salad and stuff, then
yes.
okay, got it.
Yeah. So you be careful with salads because it could treat you. And this is questions that will come out with cancer as well because it's an immune problem. Now, they're going to say which of the following will be the best diet for a patient on chemotherapy. Remember that everything should be dead that is eaten by the patient or killed by cooking. Okay. It cannot be something that is undercooked or not cooked at all. So fresh fruits, for example, that's another one. What would happen if you cannot peel a fruit? That means to say that you're going to be susceptible to the microorganisms that are found in the skin.
Okay,
Because
thank
we always think of fresh fruit and salads as being healthy, right? But when you don't have an immune system, that's going to be dangerous. Okay. Good question. All right. So you all have a
you.
good evening. I will see you tomorrow.
You too.
You have a great time. Good evening. Bye-bye.
Hello.
Yeah.
I
Yeah,
have a
Fabiola.
hi. I have a question.
Yeah.
Separate from this is regarding the nursing advanced assessment class.
Mm.
Some students were having an issue with a specific Dropbox for the proficiency exam for the lab.
Which one? I corrected all my students.
And
Nobody
it was
had a
NUR 3069. That's the class for the
yeah,
lab.
I teach that one.
Yeah, some students were having some students it's not showing on their Dropbox area. It's not showing week 8.
Are they on my class?
Some it's like, and what we came to discuss, some of the students, some people are in one class and then some people are in another one. Some people are not in the same, like if you go on the roster, some people are not in the same roster.
Yeah,
So
not
the
in
people
not in my class.
yeah, so the people like when I look at my roster, the people that are in my roster, they have the Dropbox there, but the people that are in another one, I guess, I don't know,
You're
it's
not
not
in my
show.
class though, right? You're not in my class. I
Um,
don't
it
I
says
don't
that you're a teacher assistant or something like that on the
yeah, just an assistant. No. The
okay.
reason I'm an assistant is so that just in case Dr. Parks gets sick, I can go in
Oh, so you
to
don't know.
her.
Okay.
So I will not know anything about it because
Okay.
she has to endorse it to me for me to open it up.
Oh, okay. No
And the
issue.
reason I got surprised is because I already finished my grades and I said, "Oh my God, did I miss something?"
No.
Okay.
I have you for nursing roles. I don't have you right
I
now.
will see you there. Okay.
Yeah.
That starts next week
Yeah.
already. Okay. Well, great, Fabiola. I look forward to having you.
Okay, awesome. I'll just go ahead and tell them that you have nothing to like you're not sure what's going on with that.
Yeah.
So I'll because they were saying that they're just gonna email it to her. So I just said that's what I told her. I said just email it to her, and because they've been emailing her, called IT. Nobody knows what's going on. She's not answering.
Right.
So I just told them to just email it to her, I guess. So I
Yeah.
guess. But they just told me to ask you, but you don't know. So it's okay.
I don't know. Yeah. Okay, Fabiola. You have
All
a good
right.
evening. All right.
You too. Bye-bye.
Bye.
Bye.